about the reasons for prosthesis because Dr. Yamaguchi has told us about it already. This is what O'Driscoll has learned us. The front door to the elbow is at the back, which means you need an posterior approach to do a proper total elbow. Which means you have to do something with the ulnar nerve. Otherwise you just leave it there but know all the time where it is. Otherwise you remove it and keep it out of your working space. And what about the triceps? You can split, you can reflect, or you can save it. And first in position, I prefer to do a lateral position, so on the right side of the slide. But I know from the Mori clinic that they've learned to do elbows in posterior, and just in supine position, and the elbow positions like that. But I'm not used to that. You see the tourniquet, it's on the elbow. Nowadays we don't use the tourniquet anymore. It's not, we only use the tourniquet if it's very, if we have really problems with bleedings. But normally we just leave the tourniquet off. And maybe we just put tourniquet on just during the cementing process, and immediately afterwards we just release it again. It saves a lot of pain for the patient. To be with 2 hours bloodless arm, it gives you a really problem. So next, the triceps. What to do about that? Split, reflect, save. You see in the right slide there's something strange with the picture. This is what you can read in the book. But what about the distance between ulna and radius? It's strange that somebody has drawn this in this position. So if you want to do reflecting, you take off the triceps, you come on general from medial and you turn off to lateral, which means that after, and you go through sharpish fibers of the triceps insertion on the olecranon. When you finish with your prosthesis, you have to fix back the triceps, which means you must do transosseous suturing like it's demonstrated here. The problem with that is that I've done it twice. Twice this has led to triceps necrosis. And if the patient has a problem with the triceps, they don't have problems in carrying, in normal day life during the day. In the night, they get a problem, they get visits from their arm. If you are on your back laying and you put your arm like that in your sleep and you have no triceps, the arm falls off on your head. So I have patients who are complaining about the lack of control of the triceps. So be aware, if you have bad care of the triceps insufficiency, patients are never carrying like this. So this is not a problem. This is not a problem. The problem is only during night, yes? So this is the pulley approach or Newcastle approach. It's a variation of the triceps split. Classic Van Gordon or Campbell is a triceps tong. I think Pulley has made a lot of emphasis on keeping as much as triceps fibers as possible, because the triceps has almost a muscular insertion on the olecranon, which means that if you take a large tong, a large split, you devascularize a lot of the triceps, which can lead to triceps necrosis. So what he has popularized is that you just first take off the triceps aponeurosis, which is a thin fibrous flap. You pull it down distally. Then you identify the, is there a pointer? Yes, yeah, it's a pointer. Then you identify, it's almost hard to see, the rave. It's a kind of septum, intermuscular septum, which is between the lateral and the medial and long head of the triceps. And then you go further, which you can see, this is the triceps aponeurosis flap. If you go further, then you make a lateral window along the triceps, which means you take off the muscle at the bony insertion. So you keep as much as muscle as possible in this way of preparing the triceps. And then you dissect the triceps rave, the septum intermuscular septum, about 2 centimeters proximal from the olecranon, and you create a medial window. And in this case, you dislocate the elbow and you get a real big, large view on the ocean. This is very, it gives you a lot of overview. It's a nice way of doing it. but you have to repair the triceps afterwards. What about the triceps ulna? Still, the ulnar nerve is very important. So identify the ulnar nerve and put a vessel loop around it all the time. We never use a vessel loop with the clamp because it's a bungee jump vessel loop. Bungee, bungee, bungee. So only a vessel loop with a knot, no clamp on it. This is dangerous. You see, it's someone pulling for the picture on the vessel loop. I'm sorry of that. So we go further, and if you look to, and you create a lateral and medial window along the triceps. You should do that if possible at the section. Create a lateral window along the lateral column and a medial window along the medial column of the triceps. And then you go in and you have to do a complete capsule release on the posterior and anterior side. And when you finish with that release, then you can dislocate the ulna and radius from the humerus. This is the part of the procedure when looking from lateral, and this is when the prosthesis is inside. You have a view. And you see, I forgot to put in the slide with the complete dislocation. You can really dislocate the humerus through both windows if you want. So you get a good view on the humerus side. For the ulnar preparation, is a little bit indirect view. So you have to get used to it. You have to learn from it. So this is from the ulnar medial side. Still look at the vessel loop. And to give you a little bit more, we're now using also this tricep ulnar approach with revision arthroplasty. A little bit beyond the scope of this this course, but I want you to show the extensions of the possibilities of the triceps ulnar approach. If you do ulnar osteotomy, we can reflect the triceps on with the ulna, and we get a complete view on the prosthesis which has to be removed. And so it's much easier to get the cement out. And on the other side, when everything is gone, the triceps is reflected. The triceps is laying here, just around the hormone forceps, hormone retractor, and we can also do an osteotomy of the distal humerus, and and then we take out the prosthesis here. So this is an extension. And what about how the people do with the triceps on? I think this is really working. I have to get the video started. This is what you never see with the triceps split 3 days afterwards, because you put on a plaster, you're very scared, people are exercising too early. This is a patient 3 days post-op, and she's laying on her back in bed, and she can just control her arm without getting hurt. So I think this might convince you to look at the triceps on as another possibility to put in an elbow prosthesis safely. These are her rotations. Okay. So take home, split or triceps on. I think both are working horse which you can use. It's not on this presentation, but beware that you recreate the flexion extension axis so you get a good placement of the prosthesis. And about linking and unlinked, I won't fill in the answer. I think it's still a question, but Dr. Yamaguchi has told us enough about it. Thank you very much.